I'd like to introduce Dr. Julia Carroll, who's going to talk around the importance of early detection. Dr. Julia Carroll is a Fellow of the Royal College of Physicians and Surgeons and is an active member of the Canadian Dermatology Association, the Toronto Dermatology Association, American Association of Dermatological Surgeons, and the American Academy of Dermatology. She has a very busy dermatology practice in Toronto and is also a member of the staff of the University of Toronto Medical School. So I would like to kindly welcome Dr. Julia. Over to you.
Thank you very much. So let's first talk about the impact of melanoma and skin cancer and that it's more than skin deep. I think I'm preaching to the converted here. You've all come to listen, but we hear a lot that it's just skin cancer. What's the big deal? But there's really nothing small about skin cancer, and there's nothing beautiful about skin cancer. So they are abnormal growths of the skin cells that can develop on skin exposed to sun or tanning beds, and sometimes also to unexposed areas as well. This common form of cancer in its many forms will affect over 91,000 people in Canada, and they don't discriminate. So they can be diagnosed regardless of age, sex, or race each year. So tonight we're going to just go over melanoma, basal cell carcinoma or BCCs, cutaneous squamous cell carcinoma, and then just talk about some more rare types of skin cancers as well. So in terms of melanoma, it can show up anywhere in the body and it can affect anyone regardless of age, race, or gender. Sadly, 3 to 4 Canadians die every day from melanoma. And so where does it come from? It starts in the cells, the melanocytes that are involved with producing the pigment in our skin. It occurs most commonly on the skin, but it can also occur in the eye as ocular or uveal melanoma, and also in the mucous membrane. So you can see it in the mouth, in the sinuses, in the genital area, obviously much more difficult to detect. And then where does it appear most? So in men, we tend to see it on the head, neck, and the back, and on women, the back and the lower legs. And a lot of people ask the question of why this is, and it probably has to do with just the way that we expose our bodies, where women may tend to wear, skirts or shorts, and more often men would have shirts off than women would. So you start to see those patterns based on the behaviors and where we get our sun exposure. So are you at higher risk for melanoma? So these are the things you need to be aware of. So if you get even one severe blistering sunburn before the age of 20, it can double your risk of melanoma. Skin that has a tendency to burn, so skin that is lighter in color, if you have more than 50 moles on your body, and if you have atypical moles, or we call them dysplastic moles that have an unusual shape or color, if you're light-skinned or you tend to freckle easily, and if you have a family or a personal history of melanoma or other skin cancers, that puts you at higher risk as well. And then older age also increases your risk of non-melanoma skin cancers, just because you have a lifetime accumulation of sun exposure, and then exposure to UV radiation. So that could be outdoor sun, it could be tanning beds, sun lamps, all of those things can put you at higher risk for melanoma. So these are the most common types of melanoma, the 4 most common types. So there's acral lentiginous melanoma, or ALM. That's the most common type of melanoma in people with skin of color, and it happens. Acral refers to hands and feet. And then nodular melanoma. This is the most dangerous type of melanoma because it's a thicker melanoma and a deeper melanoma. And then there's superficial spreading. That's the most common type that we see in the general population. And then there's also lentigo malignant melanoma. This is a more rare type of melanoma, although I would say oddly in my practice, this is probably what I actually tend to see more commonly, but it's melanomas that arise from basically like a sun freckle, which is called a lentigo. So one of the things that we've done as Melanoma Canada is we've partnered with Merck, and we've created a program called Practice Skintimacy. We've tried to make it easy for you to check yourselves at home. And so everyone is at risk of getting melanoma. And so we're talking about having like a close, intimate relationship with your skin to help you spot those possible signs and those symptoms, and for you to be able to check out those hard to see places, or getting a loved one to help you. So these small little actions like checking your body regularly can have a big impact. And you can go to practiceskintimacy.ca if you want more details. And they even have a fun little game. I don't know if you can do it on your computer, you can do it on your phone, where you can actually tap on different skin spots, and you're picking out the ones that are irregular. So if you want to get the whole family involved, it's a fun little game. So what are we looking for? So we're going to check our skins for, how are we doing this? We're going to check our skin for signs of melanoma. So to get started on your mole spotting journey, you'll need just a few things that you probably already have at home. So you need a ruler to measure the size of moles, you need a comb to check your scalp, you need a full length and a handheld mirror, and a friend or family member to help you look in those hard to see places. And so the way that we're going to do this is you are going to check your moles, and you'll use the ruler to measure, and we'll talk about why that's important, obviously the comb. But with the full length and the handheld mirror, what you can do is you can stand, say it's hard to see your back, but you can stand with your back to a full length mirror and then have the handheld mirror in front of you. And when you're looking at the handheld mirror, you'll be able, with the benefit of the full length mirror, to see your back. And then also you can use the handheld mirror to look in places like the genital area, places that are hard to see, but then you can use that mirror to give you an advantage point to take a look at those areas that are often overlooked. This is what we're looking for. So we call it the ABCDEs. So A is for asymmetry. So the shape of one half of the mole appears different than the other. So just visually cut a line down the middle of the mole with your eye and make sure that the two sides match. And then we talk about borders. So if the borders are irregular or blurred or ragged, one of the common signs are these little pods that you see in this photo. So it looks like there's almost like a leaf coming out of the border. Color, so if it's unusual color with different shades of tan, brown, black, or sometimes blue, gray, red, pink, or white, really any color, you want it to be a uniform color. If there's multiple colors, then that's concerning. And then the diameter, so that's where the ruler comes in. So we want a mole to be less than 6 millimeters from edge to edge, or approximately this the size of a pencil eraser. And then we talk about evolution. So a mole that's changed over time, maybe scaly, maybe bleeding. If something has changed and not changed back, then that is of concern. So a mole may be a melanoma if it has any of these signs. So you can write down any new changes to your skin and then talk to your doctor if there's one that comes up that is of concern. So these are the resources that are available through Skintimacy, practiceskintimacy.ca. So there's a Find a Dermatologist near you. There is the Learn the ABCDs of Melanoma, and then also, there is a portal to patient support groups that are connected to Melanoma Canada. And then there's also that game there as well, if you want to have a little fun with it. So let's talk about melanoma in people with skin of color. So this is something that is been increasingly on our radar. So new cases of melanoma have tripled in the past 30 years. And although the incidence of melanoma is lower in people of color, this population unfortunately has a higher mortality rate from melanoma. So we see in Black people 1 in 1,000, Hispanic people 1 in 167, and then for Caucasians it's 1 in 38. Higher risk for Caucasians, but then when we look at the 5-year survival rates, people of skin of color 70% survive, whereas people with white skin it's 92%. And I think we think that part of that has to do with lack of awareness on probably the patient side as well as physician side that melanoma is even a possibility in people with skin of color. So rare forms of melanoma, so we're circling back to acrolentiginous melanoma, or ALM. So this is the most prevalent type of melanoma in people with skin of color. So in Caucasians, it's about 2 to 8%. And then the prevalence in people with skin of color is 35 to 60%. So this type of melanoma is not related to being exposed to the sun. So, and the majority of people diagnosed with this are over the age of 40, and it occurs equally in males and females. And so how do we detect it? So unlike other types of melanoma, it develops on less sun exposed areas such as the soles of feet or under the nails. And there's some signs that something that you see might be acrolentiginous melanoma. So it may look like a bruise or a stain. Most importantly, I would say it doesn't go away or heal like a regular bruise. And over time, it can grow in size. And it might be a spot or a patch on the hands or the feet that bleeds or is painful. So these could all be signs that the cancer is growing or spreading. So what do you want to look for? So it develops again on less sun exposed areas, such as the soles of the feet or under the nails. So it's really important for both the clinician and the patient to keep in mind so that they examine these areas in patients with skin of color. So they often begin as black or brown discoloration on the sole of the foot or the palm of the hand. It looks like a bruise or a stain. It does not go away, it doesn't heal, and then over time it grows in size. So the risk factors, again, it's not related to sun exposure, so we don't exactly know why this occurs. There are theories that it's linked to genetic mutations. 10% of people diagnosed with this have a family history of the disease. And so it's really important to screen patients for family history of melanoma. And if you have a family history of melanoma, to be proactive about getting your skin checked and to mention this to your practitioner as well. And so how do we screen for this? So really, there, as we mentioned off the top, there's not enough dermatologists to be screening everybody all the time. And actually studies have shown that statistically it's better for people to be checking themselves regularly. So monthly self-exams, and then if you're doing an annual exam with your family doctor, they can help facilitate that as well. So important again to have people look at non-exposed areas in people with skin of color. And then we talk about the cubed rule, which is better for acrolentiginous melanoma rather than the ABCDE rule. And we'll talk about that in a second. So this is the cube rule. So color. So we're looking for colored lesions where any part of the skin is a different color. U is for uncertain. So if you see a spot and you don't know how it got there, so we'll commonly see on people that run, they might get bruises on their feet, or if they play soccer, things like that. But if something pops up and you don't know what you think it's a bruise, but you don't know how it got there, then it's a spot with a clear clinical diagnosis, and that can be of concern. Obviously, anything that's bleeding, something that's getting larger, and then delay in healing. So something that's been around and has not gotten better in 2 months. So there are other rare forms of melanoma, which is would be subungual melanoma. So that's subungual, sub means below, ungual means nail. So it's a malignant melanoma that occurs in the nails. So unlike melanoma on the skin, again, it's not caused by sun exposure. So interestingly, repeated injury to the finger or the toenails has been identified as a risk, and early diagnosis is very important. So if you diagnose it at stage 1A, the 5-year survival rate is 97%. If you diagnose it at stage 4, then the 5-year survival rate is only 15 to 20%. So early detection is key. So what are we looking for? In 75 to 90% of the cases, this type of melanoma develops on the big toe or the thumb. So it will present as a black-brown discoloration in the nail. It can present as a dark vertical stripe, and then it can progress to be painful or inflammatory. It can thicken the nail or split the nail. And one of the ways that as dermatologists we look for it is that it extends into the nail bed. So you'll see the pigment on the nail bed, and it can actually start to destroy the nail bed itself, which will make then the nail grow in an odd way. So this is the Hutchinson sign, which is, I was mentioning before. So that may be an indicator of subungual melanoma. So it appears as a extension of that brown-black pigmentation. So you'll see a line of brown-black in the nail, but then it will extend onto the skin on the nail bed itself. So we call that the proximal or the lateral nail fold. So that sign is very valuable, but it's not an infallible predictor of melanoma. But it's definitely one thing as dermatologists that we look for, or if we don't see, we feel much better. So what can it be mistaken for? Things that look very similar would be starting with, again, with subungual melanoma. More commonly, when you see streaks in the nails, it's longitudinal melanonychia. So these are just streaks that we see in the nails. They tend to occur more in people with darker skin types. Asian population as well. We tend to see these streaks in the nail, but they don't have that classic Hutchinson side. They don't extend onto the skin. Onychomycosis, which is a nail fungus, can cause pigmentation in the nail. And then another type of skin cancer, which is squamous cell carcinoma, can also cause some nail changes as well. So there's a number of other things, but these would be the most common things that that might be misdiagnosed when it's actually subungual melanoma. So again, we're looking for a system. How do we diagnose this subungual melanoma? So it's the ABCDEF guide. So A is for age. So more typically it's 50 to 70 years of age and African, Japanese, Chinese, Native American heritage. It's a brown-black band that's usually greater than 3 millimeters and it has an irregular border. So change, so it might be a stripe in the nail that's changed inside and growing quickly. Digit, so we've already talked about where they occur. So thumb, big toe, or potentially the index finger. And then extension of that discoloration into the surrounding nail, or I would say the surrounding skin around the nail. That's the Hutchinson sign. And then family history is also a factor as well. And then just looking at different types of melanoma. So although acrolitigious melanoma is the most common melanoma seen in people of skin of color, also remember that patients with skin of color may still present with other types of melanoma. So we have superficial spreading, which affects the superficial layers of the skin. It spreads quickly along the surface. It tends to grow outward, called radial growth. Those are more common on the trunk, the arms, and the legs. And then again, less likely to be diagnosed early in people with skin of color. It just may not be picked up because of probably not on people's radar as much. Then there's lentigo malignant melanoma. These tend to develop more on more sun exposed areas like the face, the scalp, especially in people that have less hair, or the neck. They appear as a large flat tan or brown patch with an uneven border, and they usually affect older people with very, very sun damaged skin. And then there's nodular melanomas. This is the aggressive form of melanoma that spreads quickly. So rather than the superficial spreading, which will spread out and then down, this spreads down. So its most common feature is a bump or a node or a nodule that rises above the skin surface, and it's firm to the touch. So treatment for melanoma. So we have surgery that removes the melanoma, some surrounding healthy tissue. We have very specific guidelines as to how to do that. The type of surgery really depends on how big it is and its stage, and it may also include removing some tissue around the biopsy site. We also have immunotherapy, which uses drugs to boost your body's immune system, helping it to recognize and fight those melanoma cells. And then more recently, we have targeted therapies, which uses drugs that specifically target and shut down those mutated proteins in melanoma cells and help to slow the growth of the cancer without damaging the healthy tissue. And this has been a real game changer in melanoma over the past decade or more. There's also a neoadjuvant therapy. Sorry, this is the one I was talking about, which is an emerging treatment approach that helps your immune system fight melanoma before surgery. So it works by shrinking tumors and training the immune system to recognize and attack cancer cells. There's also radiation, where we use high energy beams to kill cancer cells, often used after surgery to eliminate any remaining cancer cells. Or also we use it to treat melanoma when surgery may not be an option. And it also can be used to manage recurring melanomas. And then there's chemotherapy, using powerful drugs to kill the cancer cells. This can be taken as pills or through an injection or infusion. And sometimes it can be directly delivered into the affected limb using a technique called isolated limb perfusion. And then moving on to non-melanoma skin cancers. So basal cell carcinoma is the most common skin cancer that we see. It makes up about 75% of all non-melanoma skin cancers. Things to look for, it can be a pink or a skin-colored nodule or bump, firm. They're often a little bit translucent and they have a pearly raised border. It can be a growth that resembles a pimple or a sore. The big thing is it's something that's like bleeding and crusting, and it doesn't heal, or it keeps reappearing in the exact same spot. Sometimes it's just a small patch of scaly skin, so it almost looks like a rash, often found on the trunk or the limbs, but again, not getting better. And then there are some types that look more like a scar, so they're waxy or yellow in color. So again, just similar, just breaking it down into what exactly each of these are. So there's nodular basal cells. These are the most common subtype, most commonly found on the head, especially the cheeks or the line between the nose and the end of the mouth, the forehead, even the eyelids. So these are shiny, pearly bumps with a smooth surface. They may have a little depression in the center or an ulceration. So sometimes we describe it as having a rolled border, which you can see in that photo, and then it often has a proliferation of blood vessels, so lots of blood vessels on it. There is a cystic variant, which is soft with some jelly-like contents, but I would say that's relatively rare. Superficial basal cells, so these are more commonly found on the trunks, the arms, and the legs, seen in younger adults. So it's these slightly scaly, irregular patches or plaques with a thin, translucent rolled border. They don't always have a rolled border, but it's like a rash that's always in the exact same spot and never goes away. And then we're moving on to cutaneous squamous cell carcinoma. So this is the type of skin cancer that's from long-term exposure to ultraviolet rays from the sun or from tanning beds. Again, most likely to appear in sun-exposed areas like the face, the neck, and the hands, but it really can occur anywhere. This will be a rough, crusty bump that may bleed, and sometimes it grows a dome shape. Open sores that don't heal or they come back over and over. Raised growths with a central dip like you see in that top left photo. And then on the lips especially, you can see like a dry, scaly, or a whitish patch on the lips that never goes away. And then there are some other more rare forms of melanoma and skin cancer you should be aware of. There's Merkel cell carcinoma. So it's a rapid, uncontrolled growth of collection of specialized skin cells, these Merkel cells that can form into cancer. The main risk for this is high exposure to UV radiation from the sun or other forms of UV radiation, such as tanning beds or sun lamps. There is mucosal melanoma. So that's a melanoma that's found in the mucous membranes or like the moist part of our body, that the inner linings of some organs or body cavities, such as the nose or the mouth or the genital area. And obviously this is typically not caused by UV exposure. And then there's uveal melanoma, which is the most common eye cancer in adults. Although it's called melanoma, it's much more rare than skin melanoma. About 200 people are diagnosed in Canada each year. Unlike skin melanoma, which is often closely linked to UV radiation damage from the sun or other sources, we don't have any hard evidence to support that relationship between sun and uveal melanoma. So that is everything I have.
Thank you so much, Julia, for that presentation. And just a little touch on what we at Melanoma are doing and how we're helping to promote early detection. We launched our Mobile in 2023, which is basically a portable skin screening unit that offers free skin checks to the public. We had our first tour in 2023 and we performed over 4,000 free skin cancer screenings across 42 cities in Ontario. And we identified over 772 suspicious moles or lesions. In 2024, the Mobile was back on the road and we were in British Columbia and Quebec, bringing the message of sun safety and risk assessments. And we identified over 700 people who were at high risk. This year, I hope you've all seen maybe on local media, but we're back out on the road and we're doing free skin screening checks. And we have expanded our tour to cover Ontario, Alberta, BC, and Quebec. All dates and locations of where the Mobile will be are posted on our website 2 weeks in advance. You can check out our website at momobile.ca and you can sign up for alerts for whenever we will be in a town near you. There is no appointment required. We operate on a first come, first served basis. The second thing that we are doing, folks, we're offering free monthly skin check reminders. So again, on the screen, there's a QR code that you can scan, or we'll circulate it after the webinar. And this sign up will alert you every month in line with the full moon to complete your own skin check, just as Dr. Julia spoke around. It's a really good and effective way to check yourself at home and a nice little reminder so you don't have to forget.